Holly Bowen-Salter. Holly is a senior academic researcher and PhD candidate with the International Centre for Allied Health Evidence at the University of South Australia. Her research investigates art therapy as an adjunct therapy for defence and emergency service personnel with post-traumatic stress symptoms. To speak on research into trauma-informed art psychotherapy, please welcome Helen Bowen-Salter.
Firstly, I just really wanted to say thank you to Melissa's presentation right before mine, because it perfectly sets up what I want to talk about today. Because Melissa's work over in the US and the work that is done over in the UK and in other countries in this area of arts therapy for trauma, especially for defence and emergency services, is frankly quite a lot further along than it is here in Australia. So I wanted to talk a little bit about the research that's happening in Australia and where we're currently sitting. So the Road Home Art Therapy program, which is happening here in Australia, is a psychotherapy program which utilises arts mediums with a trained psychotherapist, Karen Foxwell. Now, Karen Foxwell will be up in our panel coming up, so she's going to talk more about the program itself and how it runs. So I won't go into too much detail about that and take away from her, but what I did want to say was that the Road Home Art Therapy program is currently the only art therapy program for defence and emergency services personnel in the country, which is individual and ongoing. There are some programs that run in short bursts across the country. This is the only one that is ongoing continuous care. And my research is looking at this program. We're looking at the feasibility, the acceptability, the perception, the economic viability of the program, and we just want to see, okay, what's this program doing and how can we expand it further for our veterans and our emergency services? So when we started this program, we came in super positive. We knew exactly what we wanted to do. We wanted to do a randomised controlled trial. We wanted to be able to come in and we wanted to say, is art therapy effective for veterans in Australia? And so we had a perfect plan, essentially. Now, things didn't quite go the way that we had planned coming in to do that trial. So what happened is we got in and we found a bunch of potential issues that we were not expecting to find. So beyond just the traditional PhD issues where sometimes people have issues with recruitment or ethics or anything like that, these were environmental and contextual issues that we could not have anticipated coming into the program. Because we were brought on as external researchers who were otherwise uninvolved in the program setup, this wasn't a platform that we were going to be familiar with coming in. So just for a little bit of context, for good clinical practice, there are certain elements that need to be included for good clinical practice. And those elements include having research and having policy and legislative and political underpinnings which support your practice. So what we're looking at is practice should guide research, and research should underpin your practice. But beyond that, we should be looking at practice contextualizing your policy and legislative kind of decisions, and your policy and legislative decisions should be protecting your practitioners and protecting people who are accessing those services. And then keeping on that theme of this integrated multi-system setup, your research is what should be providing the development for those policy and legislative decisions, and then those policy and legislative people in your political environment provide us with some lovely, lovely funding, hopefully, that will allow you to continue to do that research, which allows you to continue to do your practice. Now, what we found coming in to this setup, looking at art therapy in Australia, especially for defence and emergency services personnel, is that the research in Australia is rather minimal, but also that there is not a ton of policy and legislative action being taken in this space. There is some stuff being developed slowly over time, like with all allied health sorts of fields, but at the moment there is no real protection in place. So that leads us on to where we ended up looking at the potential barriers to us actually being able to complete a research project in this area and being able to implement a program that could be run with our veterans and our emergency services. So I'm about to bring the mood down a little bit because I'm about to talk about a bunch of barriers, but I'll bring it back up before I leave. So coming up with our barriers, the biggest one that we found was the field development. Art therapy in Australia, the field development from policy and legislative point of view is minimal. As Melissa showed in her presentation before, they have standardisation in therapist training, so you can kind of almost see this reliability happening. And we can also see a consistency and standardisation in clinical practice for art therapists in the US, same in the UK, which doesn't currently exist here in Australia. There's no way for us to keep that consistent. Because of that, the cost and who pays is not determined. So we can't say, DVA, you should be paying for this treatment, for example, because there's no way for us to guarantee that someone accessing the service in Townsville is going to get the same service if they access it here in South Australia, for example. The evidence base for practice here in Australia, very minimal, as I was saying before. Therapy comprehension among other clinicians, and also the cultural perception of the therapy among other clinicians is very poor. It's not uncommon for psychiatrists and psychologists to not have an understanding of what art therapy is. Often it's seen as a distraction technique, or, oh, we have an occupational therapist who plays with art, that's art therapy. But it's not the same as actually having structured psychotherapy with art. So now that I've taken the mood right down to all of the things that mean that we can't have an art therapy program, let's bring it back up again with what we can do. Oh, and then art as therapeutic versus that art psychotherapy. That's that understanding that having art in a hospital environment, for example, is different from having art psychotherapy. Now on to the enablers. So these are things that support these sorts of programs rolling out and these sorts of programs being developed and working within Australia. So these are all of the good things that are helping us to be able to develop this research. So we are seeing policy, legislative and cultural guides from our international counterparts, similar to international research with a rich evidence base, which you have just heard Melissa speak about, and if you were at her masterclass yesterday, she went really in depth about the changes and things that are currently happening in America around their licensing structures, around their training procedures. It's quite extensive, and that means that we have models that we can be taking and reflecting on and putting into practice here in Australia. Although, as Susan said yesterday, we can't just be relying on evidence from the UK and the US and going, they've done it, good enough, let's take that and roll. We need to know the Australian context. We're seeing a lot of national support from leaders in the area, so there have been some higher up politicians and people in DVA, people in the higher up areas, so Michael Morgan from MFS and that sort of thing, who are showing support for these sorts of programs, which is good because it means that there is more opportunity for us to be rolling them out. We're seeing evidence from people who actually come through the program. Now, this sort of evidence is really powerful because when you have someone who comes through the program who says to you, if it wasn't for that art therapy program, I wouldn't be alive today, that is a very strong, dramatic statement which says something about this works. So what is it? And we've also seen some recent pushes for more funding, which means that we've also seen more pushes for more research in these areas, which is actually how I got my PhD, which is fantastic. So thinking about what was said yesterday by David, we can't just be sitting and talking about this sort of thing. We actually need to be getting out and doing. So now I've talked about all of these barriers to us being able to roll out these sorts of programs. Let's talk about overcoming them. So there are several steps that are currently underway. The first of which are some steps from my PhD. So the purpose of my PhD is to build a research foundation that can be built upon. So we are trying to generate some really solid base evidence that can be then expanded upon and rolled out and that sort of thing. So out of the studies of my PhD, 3 of the 5 are about building this strong foundation evidence. So we've got a qualitative evaluation of the Road Homes program to support practice, an economic evaluation of the program to support policy, because someone's got to pay, An evaluation of practice for trauma arts psychotherapy countrywide. We are going to be speaking to all of the art therapists who are registered as art therapists across the country and find out how they do their practice for trauma, which not only supports treatment fidelity, which is for practice, but will also give you a scope of practice which supports policy. Other steps that are currently underway is about combating those cultural perceptions that are happening where people hear the word art therapy and they think they know what that means. So they go, oh, art therapy, that's X. So what we're looking at is potentially rebranding our art therapy program at the Road Home, giving it a new name, not changing anything about its content, just making people have to think twice before they make a split-second judgment about what the program entails. And also the advocacy that's coming out of existing patients. That is something that is quite strong at the moment. Whenever you speak to someone who has gone through our art therapy program, they have a lot of strong positive things to say. So there are still some things that need to happen to have these barriers totally overcome. Now, the first one, of course, more research of a higher rigour with an Australian context. That's always going to be something that you need. It is a constant evolving system. The other thing that we really need to be seeing is an evolution towards policy and legislative requirements, especially around the area of licensing. So arts therapists at the moment, I could go and do a weekend course tomorrow and then call myself an art therapist on Monday, and legally there is nothing anyone can do about it. Which means that if I wanted to go and work in a hospital and I was hired and I did a poor job, it would create this cultural perception that art therapists, oh, maybe they're not too reliable, maybe we won't grab those, that sort of thing. But when you have a master's level trained arts therapist who knows what to do when situations crop up, that sort of thing, you're going to see a greater care structure happen. And the only way to ensure that that is going to be consistent is to build it into our policy and legislative requirements and have arts therapists licensed to practice. And that, of course, will lead to greater practice consistency and greater training standardisation. If to get your licensing you need to have completed a master's level course, then your training is going to be consistent and standardised. Consistent and standardised training means that we can then be evaluating across multiple sites, multiple treatments, that sort of thing. We need to increase the advocacy and education about what the treatment is and what it actually contains. So as we said, one of the biggest barriers is when you've got a psychiatrist or even a potential patient who says, I think the biggest one is, I can't even draw a stick figure. So I won't be any good at art therapy because I can't draw even a stick figure. And that says that they don't really know what is involved in the therapy and that having skill is not a necessity. So if we can increase that education and increase that advocacy, we can change a lot of those cultural perceptions. That being said, there needs to be a full trauma treatment cultural shift that moves away from that biomedical model and into a more holistic treatment range. So as we were hearing a little bit earlier about, medication is not a cure. At the moment, we're in a position where that is the kind of preferred treatment method. And by moving into a model that looks at accepting treatments that are not that strict gold standard model, we're going to be seeing a lot more acceptability about referring patients into these spaces, about talking to their patients about the potential of these. So moving into those spaces is also going to be very important. And now it's blinking at me. But that is actually all I really had to say, talking about the overcoming these potential barriers that exist. I think these are barriers that we can overcome. As we've seen from Melissa's work in the US, we have seen these giant countrywide structural changes towards supporting creative arts programs as a dedicated and important part of a healthcare team. So I don't see any reason why we can't be having something similar here in Australia. Thank you very much.